The patient should understand what he should expect after having treatment. Now, if he has surgical treatment, he should expect that this PSA should drop down to what we call undetectable levels. That's on a range of 0. And also he should ask and understand whether the cancer was confined based on the surgeon's impression of the cancer and also the pathology report. If the PSA is undetectable and the cancer is confined to the gland, there's a 95% chance of cure, only a 3% chance of recurrence. Nothing's 100%, nothing's 0% in medicine. He should also understand, if he had surgery, when he will have complete control of his urine. Now that varies. That varies with the extent of the surgery. If it's advanced cancer, it's an extensive surgical procedure. It may take longer for the control of the urine to occur. He also wants to know about his sexual function. When will it improve? When will we have it? And what will we do about it? But there is treatment for it, and we all know about Viagra and Cialis are the main treatments. If that doesn't work, then there's injections into the penis, and finally there's a penile prosthesis. And so there is treatment for the loss of sexual function. So, and I want to mention that because African Americans are really concerned about sexual function. I won't go into the reasons why at this time, but they should understand that there's treatment for that. That should not prevent them from doing something that may be curative for their cancer. That's very important. So the next question that should occur prior to treatment is whether they should be treated or from surgery or consider a non-invasive procedure or active surveillance or watchful waiting. Now, if the patient is young and healthy meaning age 65 or less or age 70 and less, and there's some men over 70 who are in good health. So it's the health of the patient that's extremely important in addition to the age, not just age, but the health of the patient. There are many patients who are under 60 that are in poor health where surgery would not be appropriate. What do you do in non-invasive? Radiation therapy is the option. I personally think that radiation therapy should be reserved for people who are in poor health and who are older than 75. The oldest patient in our database was 77. This man was in great health. He jogged every day during the week, 5 miles each day, so he's in great health. Lived to be 102. So it's not just the age, it's the general health. And one of the things that you consider is active surveillance. That is watching it, but watching it with the intent to be treated. And you have to watch it closely. After the diagnosis, if you're at low risk, that's a Gleason score of 6 or grade group 1, then you will have to be seen every 3 months the first year, and tests will be done, the PSA. We now do what is called an MRI, magnetic resonance imaging, because that helps to determine whether you're having a more aggressive cancer. And then ultimately, if it's progressing, a biopsy to see whether in fact it is at a higher grade of the disease. The other way that we measure aggressiveness is through the grade group, 1 through 5, 5 being most aggressive, 1 being least aggressive. And there's grade 2 that may also be considered for active surveillance and or watchful waiting. But those are the ways we determine whether a patient is a candidate for any of those. But ultimately, it's the patient who has to decide for himself whether he wants to have surgery, radiation therapy, or consider active surveillance if it's low risk. I also want to say that if you're African American, you're at higher risk. The death rate is 2 to 3 times greater, the incidence is higher, and it's been reported that the cancer grows faster. So you really want to strongly consider an aggressive treatment versus a non-invasive treatment.